Women report higher rates of office-related musculoskeletal pain than men, but they face systematic dismissal of their symptoms as psychological, hormonal, or catastrophizing rather than receiving the same diagnostic and treatment approach men receive for identical complaints. This gender pain gap has serious consequences for women's health and careers. Let's examine the real sex and gender differences first. Anatomical factors include smaller average body frames and different muscle-to-bone ratios affecting injury biomechanics. Hormonal influences on connective tissue are genuine. Estrogen affects ligament laxity, making women more susceptible to certain injuries, and monthly hormonal fluctuations genuinely affect pain thresholds. Workplace equipment designed for average male body proportions, desk heights, chair sizes, keyboard spacing, creates ergonomic mismatches for many women's bodies. But here's where systematic bias enters. Women's pain is attributed to stress and emotions, while identical symptoms in men prompt structural investigation. Research documents this consistently. Women wait longer for pain medication in emergency rooms, receive more psychiatric diagnoses for pain conditions, and undergo less diagnostic testing before their pain is dismissed as psychological. This creates dangerous delays. A woman reporting chronic neck and arm pain might receive antidepressants and stress counseling for months before anyone orders the MRI that shows cervical disc herniation. Meanwhile, a man with the same symptoms gets imaging within weeks and appropriate treatment begins promptly. The health consequences of this delay are significant. Acute problems become chronic, and reversible conditions progress to permanent damage. True physiological differences deserve recognition without becoming excuse for dismissal. Yes, estrogen affects ligament structure. This explains why women have higher rates of certain injuries, not why their pain complaints should be taken less seriously. Monthly hormonal fluctuations do modulate pain perception. Tracking symptoms across menstrual cycles can identify patterns and optimize treatment timing, not invalidate the pain itself. Perimenopause and menopause create particular vulnerability to musculoskeletal problems through hormonal effects on connective tissue. Women in their 40s and 50s often suddenly develop carpal tunnel syndrome, frozen shoulder, or severe neck pain after decades of the same work without problems. This isn't coincidental aging, it's hormone-sensitive tissue changes that deserve specific recognition and treatment. Advocacy strategies help women navigate biased healthcare systems. Document symptoms objectively with pain tracking data, removing subjective descriptors that trigger bias. Bringing a support person to medical appointments. Research shows doctors take complaints more seriously when witnessed by others. Explicitly requesting specific diagnostic testing rather than accepting reassurance without investigation. And crucially, finding healthcare providers who demonstrate gender-affirming approaches to pain management. The workplace dimension compounds medical bias. Ergonomic equipment is predominantly designed and tested on male bodies, average male height, arm length, hand size. Women using this equipment experience higher injury rates, then face dismissal when reporting pain. Pregnancy and postpartum periods create additional vulnerability and accommodation needs that many workplaces inadequately address. Harassment and discrimination create physical stress manifestations. The woman experiencing chronic neck tension might also be dealing with workplace sexual harassment, creating constant physiological stress responses. Her pain isn't just psychological, it's genuine musculoskeletal response to environmental stressors that happen to be social rather than purely physical. The research gap perpetuates these problems. Historically, occupational health research predominantly studied male workers, creating male-centric assumptions about injury mechanisms and prevention. Recent findings challenge these assumptions. For example, women and men develop musculoskeletal disorders through different mechanisms requiring different interventions, but most ergonomic guidelines don't reflect this. Sex disaggregated data reporting research findings separately for women and men reveals differences invisible in combined statistics. We're learning that interventions effective for men sometimes don't work for women and vice versa. But most existing guidelines are based on historical research that didn't examine sex differences. For women experiencing office-related pain facing dismissal, understand that your symptoms deserve the same thorough investigation men receive. If providers dismiss your concerns as stress or hormones without adequate diagnostic workup, that's bias requiring advocacy or provider change, not acceptance. Your pain is real, the tissue changes are real, and you deserve evidence-based diagnosis and treatment regardless of gender. Document your symptoms, advocate assertively, and don't accept inadequate care as inevitable.